Welcome to the final chapter in our EKG series. Today, we're taking on a massive goal: completely demystifying the often overlooked U wave. You know, that enigmatic sixth wave of the electrocardiogram that everyone tends to ignore? Well, we aren't ignoring it today. By the end of this explainer, you're going to know exactly how to read it, spot the hidden dangers it masks, and use it like a total pro.
Here's how we're breaking it down today. First, we'll meet the U wave and get a feel for what it is. Then we'll lay down the ground rules for recognizing a normal one. After that, we'll dive into the pathology, splitting it into two distinct categories: prominent U waves and finally inverted U waves.
All right, section 1. Let's meet the U wave. Because before we can diagnose anything, we have to know exactly where we're looking.
Notice the area highlighted right here. That little blip is the U wave. It's a tiny, maybe half a millimeter deflection that happens immediately after the T wave. If you're out there hunting for it, your best bet is usually looking at leads V2 and V3. So always keep your eyes glued to that prime real estate right after the T wave wraps up.
Now, this brings us to a seriously fascinating question. Where does the U wave actually come from? Well, believe it or not, its true physiological source is still kind of a mystery. Even with all of our modern cardiology tech, the medical community honestly isn't 100% certain what physically creates it. Crazy, right?
We do, however, have three leading theories. Number one, it's the delayed repolarization of the Purkinje fibres. Number two, prolonged repolarization of mid-myocardial M cells. Or, number three, it's just after potentials resulting from mechanical forces stretching the ventricular wall. But listen, here is the absolute crucial point. While its biological origin might be up in the air, its clinical significance is crystal clear.
Section 2. Recognizing normal U waves. We really need to establish a baseline here, because you literally can't identify a giant or inverted wave without knowing what normal looks like first.
Let's talk heart rate. U waves usually only become visible when a patient's heart rate drops below 65 beats per minute. Their size is actually inversely proportional to the heart rate, so as that heart slows down, the U wave stretches out and finally reveals itself.
Okay, what about sizing rules? A normal, healthy U wave goes in the exact same direction as the T wave right before it, and its height? It should strictly be less than 25% of that T wave's voltage, topping out at just 1 to 2 millimeters in amplitude. If it's disproportionately large, well, we've got a major problem on our hands.
Which brings us to Section 3, prominent U waves. Let's look at those dangerously large deflections.
We can basically divide our pathology into two camps. Prominent U waves, meaning those larger than 25% of the T wave, are typically linked to chemical imbalances, stuff like messed up electrolytes or drug toxicity. On the flip side, inverted U waves, which we'll hit in a minute, usually point to physical, structural danger. Try to keep that chemical versus structural divide in the back of your mind.
So what exactly causes these prominent U waves? The two most common culprits by far are severe hypokalaemia and bradycardia. You might also spot them with left ventricular hypertrophy or with certain drugs. Digoxin is a big one, along with class 1A and class 3 antiarrhythmics like quinidine. Oh, and a quick side note. A lot of these exact same conditions will concurrently give you a dangerously long QT interval at the same time.
Take a look at leads V2 and V3 on this tracing. Just look at the sheer size of that second bump. This is exactly what a massive U wave looks like when a patient's potassium levels just plummet down to 1.9. I mean, it is huge, practically rivaling the T wave itself.
Now, shift your focus to the precordial leads here. I really want you to lock this visual pattern into your brain. See that distinct elevated bump following the T wave? That's what digoxin use looks like. Recognizing this exact pattern can literally be a life-saving clue when you're working up a patient for medication toxicity.
Section 4, inverted U waves. This is where things get urgent, so let's shift gears.
Let's define this aggressively because it matters so much. An inverted U wave is a negative deflection in leads that otherwise have perfectly upright T waves. Listen to me on this one. If the T wave is pointing up but that little U wave is dipping down, it is absolutely abnormal. It is highly specific for the presence of serious heart disease.
The causes behind an inverted U wave are no joke. We're talking major structural and ischemic problems: coronary artery disease, severe hypertension, valvular heart disease, and cardiomyopathy. Seeing this inversion is essentially a massive, flashing red flag telling you there's significant structural pathology going on.
And that brings us to the ultimate clinical takeaway of this whole explainer. If you have a patient sitting in front of you with chest pain, inverted U waves are a very specific sign of myocardial ischemia. This tiny, little negative wave can literally be the absolute earliest marker of unstable angina or an evolving myocardial infarction.
The clinical metrics behind this are honestly kind of terrifying. Studies show that this simple negative dip strongly predicts a 75% or greater stenosis in major coronary arteries, like the LAD or the left main coronary artery, along with left ventricular dysfunction. It's basically the heart crying out for oxygen.
Look really closely at the arrows pointing to the downward deflections right after the T wave in this tracing. This is from a patient with unstable angina. It's so easy to miss if you aren't actively hunting for it, right? But that little dip is a silent killer announcing its presence right there on the paper.
Let's bring it all home with this final end-STEMI presentation. Check out the lateral leads here, leads 1, V5, and V6. Those incredibly subtle U-wave inversions were literally the only abnormal findings on this entire ECG for a patient who is actively having a non-ST elevation myocardial infarction. Let that sink in. That is exactly why mastering the U-wave is so absolutely critical.
So, the next time you're looking at an EKG, ask yourself, what is the U-wave silently trying to tell you before disaster strikes? Thanks for watching. Stay tuned for our upcoming series on renal pathologies. Let us know in the comment box if there's a topic you would like us to post.